Aloha, and welcome back to Healthcare in Hawaii. I'm your host, Josh Green, emergency room physician from the Big Island and state senator chairing the Health Committee this year. It's been my pleasure over these past several months having an important dialogue with everyone across the state on the issues that affect us most, healthcare. Because it's my discipline, I have an opportunity to bring a lot of friends onto the program. We've had a very vibrant discussion about system-wide questions with the healthcare transformation czar, Beth Giesting, health insurance executives, Hilton Rathel, hospital administrators and leaders in that field, George Green, and so many other people, talking about issues that range from hospice care, primary care access, JABSOM's medical school, so many issues that really matter, hopefully, to all of our friends and families as we look to get health care for everyone. Today I have the distinct pleasure of having a physician on my program and a dear friend, Dr. Neal Palafox. Neal's been a leader in our healthcare community for many decades. He focuses on issues of health disparity, and that's what we're going to be focusing on today. Give you a little background about Dr. Neal Palafox first, and I'll refer to him as Neal throughout the show. Neal is a specialist on Pacific healthcare disparities, as I said, and he is a professor and former chair of the Department of Family Medicine at JABSOM. He's family practice trained, went to UCLA for his residency, and has very good credentials as well. Did his master's in public health at Johns Hopkins. He's got so many things to discuss, it's almost going to be difficult to fit it into 50 minutes, and I know that he doesn't like to have people gush all over him, but it is important to know that he's been the expert in this area of health disparities, particularly when it has to do with the compact migrants, and we're going to discuss those individuals in our state. Very dear people that often have difficulties getting health care and have health care problems that may exceed many of our other neighbors. Neal also has worked as the co-medical director for U.S. work relation related to radiation on the Marshall Islands. He was a medical director on the Marshall Islands for preventive care for many years. He just has so many credentials that it's valuable to have him on this show. So I wanted to welcome you, Neal, and have you tell us a little bit more about yourself before we dive into this issue.
Thank you, Josh. So as you mentioned, I've been fortunate to work in the Pacific for a long time, and I lived in the Marshall Islands actually for 10 years. Like yourself, I was part of the U.S. Public Health Service. Was going to stay there for 2 years. I stayed there for 10. And in those days, really kind of worked a lot with the radiation-affected people, the radiation issues in the Marshall Islands. And subsequently had programs with cancer, comprehensive cancer planning in all the U.S. Associated Pacific. That's Guam and Commonwealth and Northern Marianas, American Samoa, Federated of Micronesia, Palau, and the Marshall Islands. So quite a bit, like you say, to do with the Pacific.
And just so people who are watching our show today understand, a lot of individuals from across the Pacific come and get their health care here in Hawaii. Is that correct?
That's correct.
And do we also reach out with our healthcare system to those islands, or are they independent in their healthcare systems?
That's a complex question. Just regarding the U.S. Pacific in general, there's territories and there's commonwealths and there's freely associated states, which are independent countries.
Okay.
The independent countries are linked to the United States by compact of free association. So in reference to the compact freely associated states, which are Federated States of Micronesia, the Marshall Islands, and the Republic of Palau, they have assistance from the U.S. in general by federal grants. It's just the way that the compact, which is a treaty, is funded. Okay. And Hawaii in particular has several of the professional schools. There's volunteer agencies that go and help them intermittently, but it's something that certainly could be more systematic.
Got it. Is it fair to use the acronym COFA? Is that where that acronym comes?
Yes, COFA is Compact of Free Association.
Okay, just maybe so it's not a tongue twister for me today.
Right.
We may say that. Okay.
Yes.
So so you said you spent 10 years. What 10 years did you spend in the Marshall Islands?
Yes. After I finished my residency training at UCLA, I wanted to do something different. And when I was in medical school, even though I was born and raised in Hawaii, Josh, I really had no idea about the wider Pacific out there. I had very little knowledge about even Samoa and all the rest. But when I was in medical school, I met several people from these areas. And unfortunately, a lot of them struggle through school. And we can discuss why that is. It's just infrastructure reasons.
Yes.
But I got to know them quite a bit. And we aligned on so many things. So when I finished residency at UCLA, I said, I'm going to visit and work in these areas, and that's what I ended up doing. And so I worked in the Marshall Islands from 1983 through 1992.
Wow. I'm just so interested in what you've experienced. Could you please maybe give me a perspective and give our audience a perspective of what it was like when you got there, and what were some of the health problems that you first recognized? Paint a picture for people of what it's like when you leave Hawaii and you go deeper into the Pacific.
Josh, that was a real eye-opener for me. I always thought that if something or a country or a entity was U.S. linked, that it'd be at the very least like Hawaii or a rural area in Hawaii.
Yes.
And that was my picture. And so, but when I landed in the Marshall Islands, it was very, very different. It was extremely third world. Diabetes was rampant, very few things to take care of it. Mm-hmm. The hospital was totally disheveled. There was broken, rusted beds. The wards, I can just give you a little story, but it made the impact for me. One day on the wards in this very broken down hospital, when I first got there, there was a rash of diarrhea. So I was wondering, what is this all about? And it turns out that what had happened is everybody was getting sick from contamination within the hospital. And it was because the toilets in the hospital were overflowing. Just the mere plumbing didn't work. And so people had to hold it and try to find other avenues on the reef. And it was truly third world. Medicines would run out. We'd have no aspirin sometimes, no antibiotics sometimes.
Even though you were sent from the program, from the Public Health Service.
Right. And I think that was one of the reasons that they tried us to go out there, but the resources were so small. While I was there, Josh, there was a dialysis unit, but it was run so poorly, run out of everything all the time. We couldn't run it right. We had to close it. It made people suffer more than they would gain from a dialysis unit. It was money that was kind of poorly planned.
It sounds like people like you had to actually go in and build a healthcare infrastructure.
Yes, well, I'm one of many. I don't want to pretend that, but it was a lot of people and investment of the government there, as well as the U.S. government, to try to see how can we bring the quality and the level of healthcare to be at least somewhat reasonable in these areas and have better health outcomes. And the infant death rate, Josh, when I was there in the outer islands was 12 times that of the United States.
Wow.
They had rampant Hansen's disease, which is leprosy, rampant tuberculosis, cholera, dengue,
yes.
all the things that you would think belong to Africa or other third world countries. They were right in our backyard, right as part of the United States.
Amazing. So explain to me better, I guess, then, once the relationship began to strengthen between the United States and the COFA states, the Free Association of States, we began to fund some programs, bring some resources to these islands. Is that right?
Right. Yes, Judge. The political structure of the compact is one of the Federated States of Micronesia, Republic of Palau, and the Republic of the Marshall Islands were declared independent countries.
Okay.
The however is that the United States wanted to link them to the United States, and so that depends on your view of things, but they wanted these countries to orient in such a way that they had military strategic denial over these countries, meaning that the United States military had full control over these independent countries, whatever happened.
Right.
So the quid pro quo went away was that we provide them federal grants, educational assistance, operational funds to get them online, and the objective was, from the United States side, was to have them become democratic countries, to have them stable governments, and to bring them to be economically self-reliant. From the Marshall Islands standpoint, it was one of becoming economically self-reliant, as well as having strong health and education systems. So the part that wasn't accomplished in either goal was the economic self-reliance, nor were the necessary objectives of health and education met.
And that was where we had to beef up our partnerships, form all kinds of new programs, and
Right.
to some degree, and one of the main reasons I wanted to ask you on the program was there is a large number of individuals that come to the
Right.
state of Hawaii for both care and to live and
Right.
what have you. And so maybe let's take a half step back before our first break. How many people are we talking about total?
So, from the areas that have the biggest amount of migrants,
Yes.
so that's between Chuk State and the Marshall Islands and Palau and the different states within the Federated States of Micronesia, the thinking is there's about 60,000 migrants now across the United States. In Hawaii alone, there's probably about 17,000 migrants that come from these areas that are in Hawaii right now.
And how is their health care provided for the 17,000 or so people that are living with us?
So stepping back just a bit is when the compact was negotiated, because of the military strategic denial and so forth, one of the agreements is that the people from the compact nations can come to any part of the United States, whether it's a territory, a commonwealth, or a state like Hawaii,
Right.
move there without a green card, without a visa, and stay as long as you want, period.
Got it.
That was just part of this treaty. And so that's why they can come and, and don't have visas and
Yes.
so forth. The other part of it is when the compact was first negotiated, these folks could come and they could access federal Medicaid and a lot of the U.S. federal programs that assisted them getting into healthcare and so forth. In 1997, with the welfare reform, I think it was perhaps an oversight, it's unclear, but all of these folks who can freely migrate were taken off. So they had no longer any access, zero access to food stamps, to Medicaid. They could not get on that.
Yes.
And so then different states where these folks migrated had to pick it up, on their dime. And so, for instance, Hawaii has their form of it, they put them on the Quest program, which is a state Medicaid program.
Right.
And so that's how they got funded. Some states choose not to do that. Some states do it better than others. And some states like ours pick it up, and we can probably explore this in a little bit, is the problem is what happens when you run out of money
Right.
and you can't fill in what you thought you would be able to do for these folks.
Got it. And I think this is a pretty good place to approach our first break. I'd say this, that we've discussed this on my program many times, and that is the scope of the healthcare safety net in the state of Hawaii, whether it's adequate or not, whether you have insurance in the traditional HMSA or Kaiser or UHA insurance, or if you have Medicaid coverage, often from those same companies, and what that means and what you get access to. But when, like you say, the funds run out, the services are very difficult to access. And we know that you and I, as providers, as docs, we've often seen colleagues who might not even accept new patients or accept patients that have Medicaid. So it creates any number of problems.
Right.
So why don't we go to our first break, and when we resume, we're going to dive right into the health disparities question, so you can tell us what you're seeing as far as the health challenges for these good people, and we'll kind of continue our dialogue there.
Thank you.
All right. You're here with us, me and Dr. Neal Palafox on healthcare in Hawaii. Thanks very much.
Aloha. I'm Nicole Horry for ThinkTech. For nearly half a century, the Hawaii Foreign Trade Zone No. 9 has brought the benefits of the Foreign Trade Zone program to Hawaii businesses and entrepreneurs. DBET, the Department of Business, Economic Development, and Tourism, operates Hawaii's Foreign Trade Zone program to encourage international business and economic development. The Foreign Trade Zone's mission is to increase the amount of international trading activity in Hawaii, thereby providing employment opportunities for the residents of our island state. For more information, see ftz9.org. I'm Nicole Horry. Mahalo.
Aloha. Welcome back to Healthcare in Hawaii. I'm your host, Josh Green, State Senator and ER physician on the Big Island, trained in family practice. Today I'm joined by Dr. Neal Palafox, who's a fellow family physician and who's had extreme and extraordinary experience, I should say, across the Pacific, caring for the people that often live right among us. In this particular case, we're talking about the population of individuals that, as a result of the Compact Free State Agreement with the federal government, have often come and lived with us here in the state of Hawaii. In our first segment, Dr. Palafox explained that 17,000 individuals are here receiving health care, and we feel honor-bound to care for our neighbors like we always do in the state of Hawaii, but also to find a way to deal with many health problems that often aren't fairly and evenly dealt with across all populations. In past programs, we've talked about the healthcare disparities that exist in our state. In some cases, for instance, Native Hawaiians have had much greater difficulties getting good care for diabetes, hypertension, have had shorter lifespans, and a lot of extra complications with their health care. These issues really matter quite a lot to our people, and we've noticed that often they're associated with economic disparity or geographic disparity. But we have today Dr. Palafox, who can tell us a great deal more about health disparities, and I'd like to treat him as our expert today on this subject to first give us a good definition, if you would, Neal. Tell us what people should know about health disparities in general.
Right. Josh, the word disparity, and we're talking about health disparities in general, it's broken down disparity, so it means that there's no parity.
Okay.
And so it means there's no equity.
Right.
And when you have a situation like that, that's what you're trying to resolve. And one of the things about disparities in general is a lot of people focus on the fact that this is a value-laden situation where the reason you want to take care of it is because it's a good thing to do.
Yes.
It's morally correct. But actually, when you have disparities, and this has been borne out in a study from Johns Hopkins, they studied what the cost of disparity is in the United States.
Yes.
And disparities in 2009, that was the most recent data they had, this was published in 2012, was $82 billion.
Wow.
82 billion. And so the point is this disparities because of lost productivity and because you have to invest so much in the disparate populations, it becomes kind of lowering the water level as opposed to floating all boats. So in this health disparities, what you want to do is bring equity. And so that's, so it's not only a value like I'll feel good about this, the people deserve this. It's if we don't address it, I believe, and I think others believe, that a lot of the healthcare system in not only Hawaii but the United States is collapsing because we have so many pockets of disparities.
Yes.
And what that does is it stresses the rest of the system to try to make it work. So I believe there's a vested interest from a moral standpoint, ethical standpoint, but even straightforward financial standpoint. If you want to get a hold of the healthcare system, we have to take care of this. And disparities enters into a dialogue again of, as you mentioned, achieving parity. Mm-hmm. And so one of the things that I often, excuse me if I digress a little bit, Josh, is talking about a little bit touching on what Dr. Koholokula talked about, and I think what Dr. Chip Hickson talked about.
Yes.
In the model of healthcare, there's individual behavior,
Right.
and there's the system you interact with.
Mm-hmm.
And previously, many of us thought, including me as a physician when I was at UCLA, that the outcome of my health was determined by my behavior, my choices. The newer model is that your choices depend on what surrounds you, and you mentioned them, your economics, your level of poverty, your access to healthcare. So if I want to eat well, I have to be able to afford to eat well, those kinds of things that were already discussed on
Yes.
previous shows. So what disparity then manifests itself as is that in the system, people don't have equal access to economics, insurance, all those things. So there's a disparity in insurance, disparity in economics, disparity in jobs. They live in places it's harder to get to the clinic.
Right.
And so those disparities then turn into health disparities because they cannot access a system that a person with the wherewithal and the finances could. So the dialogue is, how do you correct those things?
Right.
So in order to correct health disparities, you have to correct disparities in income, disparities in environment, disparities in insurance, and then you can start down the line to address, the issue more fully.
Yes, and so you're saying actually, and I think we shouldn't fail to mention disparities in education.
That's
and,
a big one.
And I also know that the professor also told us that there is a disparity in justice. It's in many ways a justice
Yes.
question. And only once I'm hearing this now, second time from two people who I have a lot of respect for, that until we address those fundamental disparities in society, it's going to be very difficult to address the, quote, health disparities,
Right.
because much of what health is emanates from economics, education,
Right.
health literacy, traditional literacy, treatment as an equal
Right.
partner in society.
Right. And to draw out your point, Josh, I think if we look at the compact nations, let's just take the Federated States of Micronesia and the Marshall Islands.
Okay.
The GDP per capita in the United States is about $51,000 now. In the Marshall Islands, it's about $3,000.
Wow.
And in the Federated States of Micronesia, I think it's about $3,200. So you see and why is that important is because when the United States took these countries on and the people migrate, they migrate for a reason. So with $3,000 per capita,
Right.
how are you going to possibly build a health and education system to reach those levels where people have the educational levels? Hospitals, I described to you what the hospital looked like when I first got there. It's because there wasn't the investment in those critical things that affect health outcomes. So when it doesn't happen there, and because we didn't meet the objective of economic self-reliance, the people are going to go somewhere.
Right.
They're going to go where they feel they can get a more parity in what they feel they were promised or obligated and so forth. So they come here, and then the unfortunate part is they can't hit parity here either for lots of reasons.
Right. I can tell you my experience, my first job, as you alluded to earlier, was being a family physician in Kau on the Big Island with the National Health Corps. And many of my patients were these wonderful people, and they were many Marshallese individuals, and they're large families, for sure, living essentially in poverty, and the only healthcare service they could really access would be either coming to see me in the clinic, or of course going to the emergency room where I work now. And I'll tell you, it was shocking to me as an individual to see people with such advanced health challenges. I remember seeing one guy with terrific gout, terrible gout, and he had tophi gout. For those of you who aren't familiar with gout, large basically growths on all of his joints. Very advanced disease like I had never seen in training or in work elsewhere. I saw people with Hansen's disease, as you talked about, and when I described it to some of my friends from residency back in Pennsylvania, they were stunned to hear that we had leprosy active in the state of Hawaii. Tuberculosis, of course, like you said, because people were coming to hopefully get better care, and whether or not I provided them better care, I don't know. I know that we provided some care, but I remember still great challenges, even getting people to follow up, getting adequate medications for people, helping to support just basic transportation for individuals. So those disparities, in this case, ability to get to the office, ability to pick up medications, ability to just, be healthy enough for the family to get to school so the kids could get a good healthy meal, they were lacking. And that was my first experience as a kind of an independent physician.
Right.
And I assume that that's still going on today.
Yes, it's a little bit better, Josh, but still the struggle is huge. And in fact, there's lots of projects that we're working on with the U.S. federal government, with the Marshall Islands government, and to kind of shore up a lot of these things. And just as you mentioned, there's so many disparities in healthcare. So one of the things that is to me a very blatant example of these types of health disparities. One of the things that has transpired is when we looked at a lot of the data across the Pacific, in the Pacific in the world,
Okay.
the countries that have the highest obesity rates are all in the Pacific.
Right.
All in the Pacific, as you probably know, not by a little bit, by far.
Why is that? Why don't you tell people?
So part of the reason that obesity is such a big force in the Pacific, part of it, a small part of it, is genetics. It's that whatever the genetic components are, they tend to not process and metabolize things as other folks should. But probably the biggest issue is more than genetics. Genetics will play a small role. Is what they eat, how they eat, if they're sedentary or fully exercise, and also a lot of it is the recognition and the education around what it will take.
Yes.
And so a lot of the foods that they eat are actually, if we just were to take the compact nations, is a lot of the foods that they eat are actually processed foods from the United States.
Sure.
The amount of fish that they catch and so is very small now because of the way they urbanize and because of the way the development evolved.
Yes.
And so they're, excuse me, they tend to be more sedentary. A lot of processed foods with not good caloric or nutritional value. And I think it's the choices of what they have. Previously, all these countries were able to make very healthy foods and grow them because of seawater rising and urbanization, population growth. They can't do that anymore.
It's a cautionary tale, I think, too, because it's, though we'll digress for just a brief moment from what we're talking about today, which is just fascinating, but we are talking about health disparities in general, and you're an expert on this. We're seeing that, aren't we, in other urban settings where we have, whether people are white or they just have, whether they're indigenous peoples across the country, if there's poverty, we see where there's urbanization and poverty colliding, we also see these extra high rates of obesity, diabetes, hypertension, and I think, though it seems to be at a tragic rate going on in the Pacific, we're seeing it all across the country, aren't we?
Right. And to pull the string, I mean, we're just talking about obesity, but obesity, as you know, drives diabetes, it drives heart disease, drives strokes, it drives cancer. There's 14 types of cancer that are associated with just being overweight and obesity. So it drives so many things, and one of the things, just to again point out why this disparities issue is such a crucial force, is because all these non-communicable diseases together is what's sinking our healthcare system. They're very expensive, very chronic, very difficult to take care of. And so if we do not take care of the primordial issues, it drives the issues, it drives the outcomes, and then we're chasing the dollars to try to fix something we should have fixed with education, justice, all those basic things, and correcting disparities. And so you're right, when you pull the string, obesity on the surface things, people think, oh, all those big fat people. It's an indicator of what we've done.
I think what I'm going to do, this is just such a fascinating topic. We're going to pick up right there in a moment. We'll take a 40-second break and come back, and we're going to pick up right there on health disparities in America and health disparities in the Pacific, and talk about really what we might do to start dealing with this problem at its core. I'm Josh Green with Healthcare in Hawaii. Thanks for joining myself and Dr. Neal Palafox today.
Aloha, I'm Nicole Horry for ThinkTech. For nearly half a century, the Hawaii Foreign Trade Zone No. 9 has brought the benefits of the Foreign Trade Zone program to Hawaii businesses and entrepreneurs. DBET, the Department of Business, Economic Development and Tourism, operates Hawaii's Foreign Trade Zone program to encourage international business and economic development. The Foreign Trade Zone's mission is to increase the amount of international trading activity in Hawaii, thereby providing employment opportunities for the residents of our island state. For more information, see ftz9.org. I'm Nicole Horry. Mahalo.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, physician on the Big Island, state senator. Today I'm joined by Dr. Neal Palafox, who is an expert in health disparities, has spent his whole career working to make sure populations of people have better health, particularly in the Pacific Islands. Today, though, he's a professor at JABSOM. He's an educator and a healthcare provider. And in our first two segments over this half hour, he's spoken eloquently about the problems that we have where disparities in general drive very, very severe healthcare consequences for our people, particularly those who have come from the Marshall Islands, those who are Samoan, so many of the Hawaiian subcultures within our state, a lot of people have higher rates of obesity, have higher rates of diabetes, have untreated hypertension because of so many factors. And I want to pick up right there, Neal. You said that disparities are not just about health. They're about many parts of life, and they're driving incredible healthcare costs in our country.
Right.
I think on previous shows we've mentioned that over $300 billion is spent on diabetes alone now in our country.
Right.
So now that we've had the Affordable Care Act, and it's made an attempt to get more people insurance and perhaps get more people moved towards primary and preventive care, do you think that's the answer? When we talk about these health disparities, it seems like there's something much more fundamental that we need to do as a country to take better care of our people and the people that are here with us in Hawaii. What do you think?
I agree, Josh, with what sounds like your thoughts about what the Affordable Care Act and reform can do and what it can't do. But I think it's going to take a transformation, a true transformation of our thinking, and I think that transformation hasn't taken place. A lot of people all over in the United States believe that the answer is the healthcare system. And furthermore, they believe that it is hospitals and it's investments in actually new technology and new medicines that will somehow get us out of this. And my personal belief in analysis, that couldn't be further from the truth. That is on the opposite end of the spectrum. What we should do and what we've been talking about is prevent people from getting there in the first place.
Yes.
And that can be done. And if it certainly isn't done, has been, and it's been borne out by why the Affordable Care Act and other folk, the United States is reeling in healthcare dollars, is because that's the previous system we believed in. It's collapsing. It doesn't work, period. And I don't think, I hope nobody believes that that's going to work anymore. So I think to address all the primordial determinants of health, it's not hospitals, it's not clinics, it's not even vaccinations. What it is putting in place those things which allow people the choices and the wherewithal to be healthy. So it's, again, the economics, it's the jobs, it's the ability to think through situations, it's the ability to get nutritious foods. And we were talking a little bit ago about the unhealthiness sometimes of the people in Federated States of Micronesia and the Marshall Islands. A lot of that is because there's great disparities there where they can't afford foods. And just from an education, showing you the power of education.
Yes.
The population that migrates here is an exact image of all people there.
Okay.
Because they can freely migrate, and
Right.
it's fairly close. And so in Hawaii, 33% of the adults do not have a high school education that come from these areas. A lot of the educational systems that were supposed to be developed and robust, when they finish high school there in the public system, they read on the 4th and 5th grade level.
Wow.
So it's just to show that the disparities there play out when they come here.
Let me actually dig into that a little bit more.
Yeah.
You made so many points. It's fascinating to me. So first of all, you say that 33% of the individuals that come, only 33% have achieved full high school education. Is that
Right.
correct? But even of those 33%, the quality of the education really only got them to, say, a 4th or 5th grade reading level.
Right.
So in effect, a gigantic majority of those who come do not have adequate education to at least even present themselves as a person that has high school training and would be able to go get a basic job in the state.
Right.
Okay. So that's a very, very large strike against anyone trying to come and deal with the many health disparities and
Right.
social determinants of health
Right.
off the bat. Okay. Of the people that come, are you suggesting 9 out of 10 people might not have even an equivalent high school education that come to Hawaii? Is that possible?
Well, it's a big percentage. I don't know the exact percentage, but it's a big percentage, and then you throw on top of that the linguistic and cultural barriers.
Right.
So all of a sudden you have a very a huge force that's working against them, so to speak, in our system.
Right.
Because our system works on you have to be able to have a fairly high level of health literacy.
Yes.
And I was reading a document just recently that in the United States, most of things that are written in hospitals and so forth are given in a 10th grade level.
Right.
And that's for U.S. education.
And people who are English as a first language.
Fail miserably. I mean, so
Yeah.
even health literacy in the United States is not where it should be. So you can imagine migrants coming through. And one thing I just want to say, because a lot of other folks tell me, oh, well, you know, there's people who from Japan and the Philippines and, you know, China who immigrate here, and, you know, they don't have the same problems. Why is this such a big deal? Well, a couple reasons. One is the demographic that immigrates from India, they're of a much different class,
Yeah.
much more educated. They have sponsorship here. There's people who sponsor them so that they can come.
Yes.
So it's not the demographic of their entire country. It's a very skewed demographic. So they can be successful.
Yes, it's apples and oranges because those people are already primed for success when they come to Hawaii. Whereas those who, as you stated earlier, who come from Micronesia or any of the compact-free states are a pure reflection of the challenges that already exist in that. And now, let me, because we have so little time and I have so many questions for you, so you've established that there are these social determinants of health, and it really makes it very difficult to get good health outcomes, quality health care, and healthy people that come to the state of Hawaii, which we have to work on completely. Are we doing a couple of things? Just let me rapid fire question you, Neal. Does the United States provide any education or any educational services in these states, on these islands? Do we help educate people?
Part of the compact agreement is to have operational funds for the education and health sector. Is it sufficient? Probably not.
Okay.
And is it organized in a way that it all fits? Probably not. So there are funds. I think there's a long way to go on both sectors, both governments' parts.
And then economic development. Are there economic development opportunities so that people, if they're going to come and live in Hawaii or other parts of the country, are there, is there job training? Is there preparation for individuals so that they can come and integrate into society in a, in maybe a fair way?
Josh, they're trying to work on that here.
Yes.
It's a big hole, and I think people are just coming because of the opportunity. But there's too much demand. It's not systematic on this end. But I know lots of people are trying to work with it and find resources to make it happen.
And I think that it's been very interesting to have some of these conversations because, for instance, though it wasn't specific to this group of individuals, when we had conversations and had some seminars recently from the Healthcare Association, I know that they've been working with the banks, for instance, across the country to do needs assessments and assess what we might be able to do with the core of our healthcare system. And health disparities have come up repeatedly. I don't know that they've come up in the context of the COFA migrants, but they have come up and focused on, for instance, those who are Native Hawaiian and those who are Filipino and those who might otherwise be challenged with some of the health indicators. But you seem to be saying that in many ways we're asking the wrong question, because a lot of these seminars people say, well, should we build a health center? Should we build a hospital? Is that where? Should we put several doctors into a community to get better healthcare outcomes and decrease the disparities? You're actually saying something somewhat different. You're saying that we perhaps should be investing in much more fundamental infrastructure in certain communities and across the Pacific in order to get people to a place where we first remove the pre-health disparities and then can begin to address the health disparities. Am I framing that correctly?
Yes, Josh, you hit it right on the head. When they actually looked at the impact of the healthcare system, and the healthcare system meaning clinics, hospitals, vaccinations, that whole rubric of, if you added all that together, and let's say in Hawaii that worked perfectly.
Yes.
Perfectly, everything was smooth, and we know that there's issues with that.
Right.
It would only affect 15%, 1/5 of the healthcare outcomes. All the rest is all this other stuff.
Wow.
And one of the things they've studied disparities in Kentucky, and they showed that if you have a household in Kentucky, and that is $60,000 a year, versus a household that's $100,000 a year, the people in the $100,000 a year household will live 7 years longer. Just that alone, they control for everything else. So, and then education-wise, if I have a full high school education
Right.
versus a college education in the United States,
Yes.
I will live 3 years longer. And that's just if it's high school versus, but you can imagine if you don't.
Yes.
And they've actually looked at even if the services are available. So they looked at in Hawaii cervical cancer screening access,
Yes.
and they found out that if you're high school or less than high school or less educated,
Yes.
you only access the available systems 63% of the time. If you're in college or better, it goes up to 89% of the time. So that the drivers of even if you do have access, education is this huge part of that, and so that should be the biggest investment.
I so agree with you. I was hoping you would actually say that as directly and cleanly as you did, and that is that from my perspective, healthcare reform must be education reform. It has to be access to meaningful progress through high school to get that degree.
Right.
And then another increment of meaningful progress for society, for large parts of our society and big pieces of our families through college if they choose.
Right.
Because all of that opportunity gets translated into not just accessing the healthcare system, but accessing healthcare decisions long before
Right.
we ever come to the point where we need bypass surgery or we've missed an opportunity to get basic cancer screening like cervical cancer screening. So I've very much appreciated an attempt to get our healthcare system kind of righted and get people access to insurance and so on. I have been concerned that lost in a grand dialogue and lost in a big political fight has been the fundamental issue, which was lifting people up in their lives by giving them so many more opportunities by having an education. That was lost in the dialogue. I would tell you that even though I read so many of the transcripts of the debates and then watched so much of it on television along with you and so many others, education was very, very rarely mentioned when they were debating healthcare. And I think that that is probably going to be the task of the next healthcare leaders in our country, to relink healthcare and education so that when we take on these problems, we're not starting out with perhaps even a no-win situation. I think what we should do is we should take our final break now, and then I'm going to come back to you and say, Dr. Palafox, what will your vision be for the next 10 years to help solve some of these healthcare disparities in our country, and particularly here at home in Hawaii? Okay? Okay, great. Thank you for joining us today. I'm Josh Green with Healthcare in Hawaii. It's been a very excellent discussion with Dr. Neal Palafox, expert in the area of health disparities. Thanks for joining us.
We want to thank our underwriters.
Hawaiian Electric Company and its affiliates Maui Electric on Maui and Hawaii Electric Light Company on Hawaii Island are deeply committed to the communities they serve.
Galen Ho is a senior executive of BAE Systems, a global defense, security, and aerospace company.
The High-Tech Development Corporation, the state's leading technology agency, attached to the Department of Business, Economic Development, and Tourism.
Castle and Cook Hawaii, with a time-honored legacy that spans more than 160 years and revolves around its mission of investing in Hawaii, creating communities, and providing for the needs of our state.
Hawaii Gas, formerly the Gas Company, a proponent of the Liquefied Natural Gas Initiative, helping Hawaii achieve its transition to clean energy and a better energy future.
Collateral Analytics, a Hawaii-based tech company empowering the real estate industry with greater and faster access to the tools and data they need to make better informed property investment decisions.
I'm Nicole Horry. Thanks so much for joining us on Think Tech.
I'm Maria Kashem. See you next time.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, physician from the Big Island and State Senator. Today I'm joined by Dr. Neal Palafox. We're having a very exciting discussion about health disparities. Neal, because he's a leader in healthcare and healthcare transformation and has spent so much time working both clinically and in the area of healthcare systems, has been able to really educate us on what we have to begin to rethink when we talk about healthcare transformation. In the first about 45 minutes, we spent a great deal of time talking about healthcare disparities. And I'm going to turn it back to him here in about 10 seconds, and I'm going to ask Neal, Dr. Palafox, Looking forward for the next 10 years, having already experienced the Affordable Care Act and healthcare reform, which we agree has been inadequate to address some of the health disparities that will ultimately create solutions for our country and our citizens here in Hawaii, what do we need to do to make this healthcare system work for our people and the people all across the Pacific? A small question for the last 5 minutes.
So, thank you, Josh. I think that the fundamental thing that needs to be changed is the way we think about healthcare and the way we think about fixing the system, so to speak. The system is fixed not by technology and not by the medical model per se. It's really fixing all the systems that, as you mentioned, Josh, the primordial things that affect healthcare. And in order to get there, I somehow think that many people get stuck on the paradigm of if healthcare goes wrong, an individual has made a wrong choice, and therefore it's their fault. And then they screwed up, and so therefore they got to bear the brunt. As opposed to the system, the social organization that we have did not work for them. It works for people with the wherewithal, but it didn't work for them. So the social organization, which includes education, finance, income, environment, has to work. And if it doesn't work, we are heading for a bad time. So this should be a transformation of thinking of everybody, not I'm trying to help the poor people, but it's because this is how America is going to succeed. And if we don't, healthcare costs, as you've seen, it'll sink us. Non-communicable disease epidemic is sinking many countries. It'll sink us. So this is something that is not, should we have to. And I believe the only way we can do it is by the ways we discussed, that total transformation of thinking and approach.
It's fascinating to me because, number one, the challenges when people have their minds set that healthcare reform is about fixing hospitals and just fixing the number of doctors, it's both, not that we shouldn't do that and have more physicians as we believe and have good hospitals everywhere when they're needed, but those are the structures that are controlled historically by insurance dollars, by decision makers who build hospitals, hospital executives, very good people that you and I work with a lot. However, they don't get to the root of many of the problems. And what you're saying, it seems, is we can build all the hospitals and train all the physicians we would like, but we're only going to take on a small part of the solution. And the much larger problem, if left unaddressed, will bring us all down. Right. So we're going to have to rethink our process. We're going to have to, it appears, invest in education properly, health literacy, economic development, economic fairness. And to do those things, as you know, we have to change our life philosophy as Americans, actually. We're going to have to focus on what is the right investment in our own human capital. And I know a lot of my friends will complain when I talk about that, and they toss out words like welfare and charity. But I'll tell you what, one thing is, of course, it's compassion, that we all take care of each other. And all of my friends agree politically and professionally agree that we should be compassionate. But I think we're going to have to begin to make the argument that it's a good human investment, both capital and health, to invest in really good early childhood education, really good public schools, really good health programs, and really good job opportunities for anyone who's going to come to our country. And perhaps that's where we'll have to begin the next phase of our discussion, because I do hope that we'll have a lot of opportunities. You've been one of the most compelling people that I've ever been able to speak with, because your breadth of knowledge is so vast on healthcare. Do you have any closing words you'd like to convey to people out there making healthcare decisions for Hawaii, say?
No, just thank you, Josh. And I think it's to just stop and think a moment and think, are there other models that are better? Just open our minds to just that. And I think if we cross that barrier, people then see perhaps we can move this system, because I think it can be moved.
Okay, well, on that optimistic note, we're going to stop. But today I'd like to say thank you, Neal, for joining me. I'm Josh Green with Healthcare in Hawaii, your physician from the Big Island, and today I had Professor Neal Palafox helping us work on health disparities both in Hawaii and across the country. Thanks for being with us.